adhere to your time. The next speaker, Dr. Rajeev A. Anagiri, he says, your tissue or my tissue doesn't matter, it can be saved, states Dr. Rajeev A. Anagiri, the senior nephrology consultant, all the way from Apollo Hospitals, who after the UG in Karnataka and PG in Maharashtra flew to Canada for obtaining his FCN. He completed his International Society of Peritoneal Dialysis Fellowship Program, member of the Task Force for Hemodialysis Guidelines for Indian Society of Nephrology, 2013-2020, ADQI 18 for Guidelines for AKI in Developing Countries, 2017, and the AKI Guidelines for 2022 for this recent conference. He penned 38 publications in peer-reviewed journals as well as reviewer for 12 nephrology journals. So for those nephrologists who have a dilemma on allograft when planning to do a surgery, kindly give them to help them to save the patient and the tissue with your deliberation on late allograft failure is salvageable.
Yeah. Thank you. First of all, I would like to extend my thanks to the organizing committee as well as the scientific committee for this kind invitation. The topic given to me is late allograft failure is salvageable. I'll try to make a case to justify this statement. Since the inception of a kidney transplantation, it has become a treatment of choice for end-stage kidney disease patients, which offers benefit in terms of cost as well as quality of life and most importantly survival over an alternative treatment of dialysis. And in the last 3 or 4 decades, there have been a marked improvement in the early graft survival. That is, 1 year survival is about more than 93% in the last couple of decades, whereas the long-term outcomes have been quite poor. And in most of the centers, even the best of centers, the 10-year outcome of a kidney transplantation is only about 50 to 60%. And this unsolved critical issue of a poor long-term outcomes is the focus of researchers as well as clinicians in the last couple of decades. This is a slide which shows that recent data from the American registry. You can see that the graft survival over a period of about 10 years goes slowly down. Even though there is some evidence to show that there may be an improvement in the graft survival even at 10 years, a very minor improvement. So before we embark on trying to salvage the kidneys in the long term, we should know what are the causes of allograft losses in the long term, that is beyond 5 years. And these can be divided into 2 groups. One is the immunological, other one is the non-immunological. Immunological, as you know, it's a cell-mediated rejection and antibody-mediated rejection. Even the viruses such as CMV and BK virus can affect the kidney or injure the kidney by immunological means, but generally they occur very early in the transplant. These are the first 2 years. Even though they occur early, the consequences can be quite late, and you can have allograft dysfunction even after 5 years as a consequence of early virus infections. As far as the non-immunological causes are concerned, organ viability is one of the major factors, but is a non-modifiable factor, so I'm not going to discuss that. There has been a lot of talk about drug toxicity, especially CNI toxicity, which can affect the kidneys in the long term. I'll deal with that a little bit. And more importantly, recipient-related factors such as diabetes, pre-existing, or a de novo, or hypertension which is poorly controlled, recurrence of diseases such as glomerulonephritis, as well as the de novo glomerulonephritis, and of course non-compliance of medication, which is a major determinant of a rejection in the long term. And there are other issues like lipid disorders, obstruction infections, which I'm not going to deal with that. So the chronic allograft nephropathy has been a term which I've been using for a very long period of time, and we use very loosely as a clinical diagnosis, but CAN is basically a histological description of a which is not associated with any specific cause. And IFTA can be, this basically refers to IFTA, which can be mild, moderate, or severe, as shown here. And what we are interested to deal with is the chronic allograft dysfunction, which is a clinical condition characterized by a slow deterioration of the kidney function over a period of weeks to months, and is generally associated with worsening of hypertension as well as proteinuria. And as you can see, the chronic allograft dysfunction can be due to CAN as well as other conditions such as antibody-mediated rejection, recurrent or de novo glomerulonephritis, BK virus nephropathy, late rejection such as TCMR as well as the recurrent TCMRs, and renal artery stenosis, and so on and so forth. So this is a seminal study which was published about 10 years ago, which comes from Edmonton Hollerans unit. What they looked at was the 315 allograft indication allograft biopsies and followed them over a period of about 32 months. And what they found was most of during this period about 64 kidneys were lost. And when they analyzed this 64 allograft losses, they found that the majority of causes was due to the ABMR. That is almost about 2/3 of the patients. Some very few patients have mixed reaction, but most of them were due to antibody-mediated rejection. They also found that about 18% had glomerulonephritis recurrence as a cause of graft failure, and some other conditions such as polyomavirus, which caused late allograft dysfunction beyond about 5 years. And also noted very important fact that almost about 50% of cases had a non-adherence to the medications, which is again a major contributor for this ABMR in the late stages. And the other side, the panel shows here that what are the causes of late graft after about 5 years. You can see that the ABMR is the major cause of graft losses, followed by IFTA as well as recurrence of glomerulonephritis. So let's focus more on the ABMR, which seems to be the major cause of graft dysfunction and loss after about 5 years. And the criteria is basically three: the histological criteria, evidence of acute or chronic antibody-mediated allograft injury. There is a cytological evidence of donor-specific antibodies, class 2 and also class 1. And there could be again non-HLA antigen antibodies against non-HLA antigens. And also the third important evidence, that current or recent evidence of antibody interaction with endothelium, which is again evidenced by the C4D positivity in the allograft and a microcirculatory injury in the allograft. So we need to have all these factors to make a clear-cut diagnosis of ABMR. And this is a study which we are very familiar with. This is a non-KVS from Sydney, Australia. They did a protocol biopsies over a period of about 10 years in about 120 patients. They found that at the end of 10 years, almost everybody had a IFTA, and about 58% had a severe degree of IFTA. And they attributed all this injury to the kidney to the dose-dependent calcium toxicity. However, there are some major issues with this study in the sense that the C4D staining was not done and DSA was also not available in this patient. So the attribution of this injury to the calcium inhibitors was probably not correct. And there seemed to be a lot of disagreement with this notion that the CNI is a major contributor of graft loss in the long term. And this is basically that Edmonton unit which I was talking about. And they reported not a single graft was lost because of calcineurin inhibitor. Of course, their duration of follow-up was only about 3 years, and you may not expect calcineurin induced IFTA could be lost within a matter of 3 years. But having said that, the truth seems to be somewhere in between. The CNI toxicity is probably not a major contributor of graft loss in the current scenario. It may probably cause a graft loss in about 10%, probably not more than that. And more importantly, the recent evidence from the liver non-organ, non-kidney transplant scenario has shown that CNI toxicity is probably not a major problem. This is a study which was published about 10 years ago, which they looked at the liver transplant recipients who had a GFR about 60 to 100 ml at the end of 1 year, and they followed these patients for about 10 years. They found that there was absolutely no change in the GFR at all. Again, indicating that CNI toxicity is not a probably major factor in these patients. This is a new entity, which is a chronic active TCMR, which is again alludes to allograft biopsy showing inflammation in the IFTA in the context of features of acute T-cell mediated rejection. It is described in 2017, and the criteria has been refined in the last three years ago at Band conference. We are not entirely sure what is the cause of this chronic active TCMR. Probably it's a
So people
Uh, the chronic active TCMR is a new entity which is described in 2017, and the criteria have been refined in 2019, and it basically alludes to allograft biopsy showing inflammation in the IFTA in the context of features of acute TCMR. We are not entirely sure what is the cause of this kind of injury to the kidney. It's probably related to under immunosuppression. Also could be because of due to the non-HLA antibodies and probably other unknown factors. In the recent times, I had seen a couple of patients of this chronic active TCMR patients following a COVID infection. So some other injuries, probably viral infection, can trigger this kind of rejections. And this is a table which shows the recurrence of glomerulonephritis, the allograft. I'm not going to go into the details. Just to say that the IgA nephropathy can be an issue in the long term. We have been seeing the last few years IgA recurring and causing a graft injury as well as graft loss over a period of about 10 years. And other things you are all familiar with. So we should not forget that the impact of hypertension on the graft outcomes are long term. The hypertension is probably universal in the post-transplant kidney recipients. And Kasiski et al. Estimated that every 10 millimeter mercury increment in the blood pressure, systolic blood pressure above 140 millimeter mercury was associated with an increase, 12% increase in the risk of graft failure and 18% risk of death over a period of about 10 years. And we could use a RAS blockade in patients who had proteinuria, and we can use a calcium channel blockers in early transplantation to ameliorate the CRDAT-mediated vasoconstriction. And this is a graph which shows that NODAC can have a major impact on the allograft outcome. It is a risk factor for graft loss, CV, cardiovascular morbidity, mortality, and overall mortality. And the tight control of blood sugar probably might make a difference in the long term. We have been seeing patients with beyond 5 years who had diabetes or NODAC, developing diabetic nephropathy allograft, and we should probably tackle these issues very aggressively. So coming to the evaluation and prevention of allograft dysfunction, what we can do, these are all the investigation we would like to do. I would like to emphasize on two important tests, that is a donor-specific antibodies. If you have a donor available to you. If you do not have the donor available to you, we can use a single bead antigen assay, especially for the class 2, because that probably is what makes a difference. And allograft biopsy, histology, and C4D staining is probably very important in making a decision in these patients. So if you want to look at the what allograft the functioning or the status at 5 years, probably you can take a snapshot of this at about 1 year. This is a Hurrier unit which showed that the GFR at 1 year, at the end of 1 year, also proteinuria at the end of 1 year is a very strong predictor of what would happen at the end of 5 years. So if you make a clear-cut evaluation at the end of 1 year in all aspects, including the donor-specific antibodies, probably you can prevent a lot of allograft dysfunction by intervening. This is another study which showed a clear-cut correlation between the GFR at 1 year as well as at 5 years, almost linear correlation here. And they looked at the multivariate analysis. They found that the GFR at 1 year was probably the strongest predictor of what the GFR would be at the end of 5 years. So in addition, this albuminuria, we do not generally do albuminuria quantification. Probably we should be doing it at regular intervals. This is a study which was published recently where they looked at, this is a sub-analysis of a favorite study where the vitamins were given for this transplant patient. They looked at this proteinuria at a vintage period of about 4.1 years, and the GFR was about 49 patients. That means very good, well-functioning kidneys. They showed that macroproteinuria or macroalbuminuria was a major predictor of events, that is a hazard ratio of 3.4 for a graft loss over a period of 4 to 5 years. So looking at the HLA antibodies and graft loss, this is an interesting study from Brazil where they looked at 500 patients who were functioning very well at more than 3 years. And they take a snapshot of a DSA at one point and at a median period of about 4.4 years after the transplantation. And looked at two important aspects, HLA DSA as well as anti-HLA antibodies as well as the change in the creatinine from the baseline. And they showed that if you have HLA-2 antibodies, you can have a very significantly increased graft loss over a period of about 3 to 4 years. And if you have a combined increase in creatinine as well as HLA class 2, it can be much more problematic than otherwise. And they also showed that HLA class 1 probably may not have any major significance in the late transplant period. So what about the kidney biopsy? Of course, kidney biopsy is critical in diagnosing acute rejection, ABMR, both acute as well as chronic ABMR, so, recurrent and de novo glomerulonephritis, and of course, BK virus nephropathy. The protocol biopsies have been practiced by some centers, but of late it has not been shown to be very beneficial. A recent randomized study which by Rush et al. Showed that when they subjected patients to protocol biopsies versus no protocol biopsies, they found that ACR, the subclinical rejection was shown in a very small number of patients, almost about 4.6%, which is minute, and they did not show any difference by doing a protocol biopsy in terms of outcomes as well as acute rejection episodes. When you do a kidney biopsy, always ask for a C4D staining. And in the late slow creeping creatinine situation, for example, beyond about 5 years, creatinine is slowly increasing, you have done all the basic investigation. If you do a biopsy, you are not likely to see a major benefit in terms of a change in the management. This is a study which was published way back. They found that only about 20% had a major change in their management when the biopsy was done in these patients. And mostly these modifications mainly done for the CNI dose modification. Of course, we do not have any recent study to really justify this, but protocol biopsies have probably not been practiced or probably not justified in the present immunosuppression era. So how do you manage? The next 5 minutes, I'll try to see what we can do to salvage these kidneys. And the emphasis should be on the ABMR because this seems to be the major cause of graft losses, and the standard of care basically is drawn from the margin used in Minnesota University. And this one suggests methylprednisolone boluses in the form of 300 to 500 milligrams daily for 3 days, or a dexamethasone with a rapid tapering, and give IVIG 200 milligrams per kg every 2 weeks for 3 doses, and also increase in the baseline immunosuppression by about 20 to 25%. And they also suggested with some non-randomized studies that in addition to this standard of care, 2 doses of rituximab in the form of 375 milligram per kg given at 1 week interval may improve the outcome in these patients. In the late ABMR, the plasma exchange has not shown to be beneficial, and most of the protocols do not use this in the late ABMR, whereas it is a part of the protocol in the early ABMR. But we are focusing mainly on this late graft losses. So in these patients, plasma exchange may not be justifiable. Of course, you have to give a PCP prophylaxis, CMV prophylaxis in the patients when you have heightened the immunosuppression for a short duration of period. And this is a study again from the University of Minnesota that they looked at these patients, 78 patients, those who had a standard of care, which is here the outcome was quite dismal. What you can see over a period of 3 years, almost like 70% graft loss. When they added these 2 doses of rituximab, they were able to show a significant benefit. So indicating that is probably maybe a good addition. So if the first line of treatment, that is a standard of care plus this rituximab fail, what do you do? There is some good evidence that bortezomib may be useful in the early ABMR, but a recent study, a randomized study showed that it was not probably much of benefit in the late ABMR. If bortezomib is given, it is given in 1 or 2 cycles of 1.3 milligram per meter square subcutaneously on day 1, 4, 8, and 11. And there are other immunosuppressive agents, other interventions such as splenectomy and all that have been used, but the evidence is not very strong in this patient, in these interventions. So what do you do with the chronic active TCMR, which is a new entity? When the attending physician was asked about what do they do, they were very variable. Steroid seems to be the one which everybody seems to agree, and addition of ATG and other things may be tried. And this is a recent study which looked at 44 patients of chronic active TCMR who were given steroid and other intervention. They found that only about 20% of the patients responded very well to steroid, and indicating that this entity is probably not a homogeneous entity, probably end result of very many different sort of injuries. So still is worth trying with the steroids. Maybe in some patients you can probably even use ATG. So these are the meta-analysis which we have recently, the reduced CNI MMF versus standard CNI. There is definitely evidence that there is an improvement in GFR, improvement in the graft survival without any increase in the episode of acute rejection if you reduce the CNI dosage in these patients, especially after about 3 to 5 years. And what about conversion from CNI to mTOR inhibitors? Of course, there is improved GFR, but there is an increase in instead of acute rejections, which are most often amenable to steroid pulses. And generally, there is no effect on the graft survival. So you have to be very careful about this. So how do you choose to minimize or modify your immunosuppression? Avoid minimization of CNI in patients who have complete mismatch of class 2 antigens, patients who are very young, who have an increase in incidence of rejections, high risk of patients with high risk of rejections like second transplants and previous
Rajeev,
PCMR.
another 10 seconds.
Sorry?
You have to another 10 seconds, please.
I lost two minutes for a stoppage. So choose patients very carefully. In these patients who have HLA class 2, good HLA match for class 2, low rejections, DSA negative, single bead antigen negative, and who do not have a, those who have a suspected nephrotoxicity. So RAS inhibition, there is an opinion is divided. Probably there is not much evidence really strongly suggested, but may be used in proteinuria patients. And chronic allograft dysfunction is basically a chronic kidney disease and allograft. This is again referred to as CKAD. Again, we have to use all these interventions to protect the kidneys in the long term. And one advice is that not to push too much of immunosuppression in patients who are already very weak, who have increased incidence of infection. So you're trying to revive the kidney, you may end up losing the patient. So this is a word of caution. So just to conclude my talk, the cause of majority of allograft failure is basically the ABMR, and the focus should be on preventing these episodes. Other causes could be late cell-mediated rejection, chronic active TCMR, glomerulonephritis, and a non-compliance seems to be a major contributor for these late rejections, especially ABMR, and we should focus our attention on improving the compliance. And early detection of allograft dysfunction, identifying its cause and early intervention can reverse this progression of graft failure. And transplant is basically a fine balance of managing the immunosuppression. I hope that we all achieve this kind of balance in our patient. With that optimistic note, I end my talk. Thank you.
Thank you, sir.